Good afternoon, and thank you everyone for joining me today for another Leadership Dialogue session. I'm John Haupert, President and CEO of Grady Health System and Board Chair of the American Hospital Association. I'm looking forward to our conversation today as we focus on yet another critical issue for our nation's hospitals and health systems. And that is how we field and how we can influence and drive improvements for our patients and communities that accelerate health equity. For those who know me, you know that I feel strongly about our field's responsibility to address the social determinants of health, those elements that can act as barriers to health for too many within our communities, and that often negatively impact health equity as well as an individual's overall health. I'm pleased to share that just this past Monday, Grady participated in a very important discussion about Black health in Georgia. Our Chief Health Equity Officer, Yolanda Wimberly, led a fireside chat with HHS Secretary Haupert Pesquera. The event was attended by several elected officials and top business leaders in the Atlanta area. AHA, through the Institute for Diversity and Health Equity, is active in helping hospitals make impactful and sustainable change that will increase equity and inclusion both within healthcare organizations while also building community partnerships and enhancing trust in vulnerable communities, improving access to equitable care. I'm very pleased to introduce our guest, an individual who is living this mission every single day. Let me introduce Marcos Pesquera. Marcos is the System Vice President for Community Health and the Chief Diversity Officer for CHRISTUS Health. CHRISTUS Health is a not-for-profit health system including more than 60 hospitals and long-term care facilities, 175 clinics and outpatient centers, and dozens of other health ministries. At CHRISTUS, Marcos leads the integration of diversity and inclusion strategies, cultural competence, and community partnerships to impact population health and achieve health equity. Marcos has also shared his expertise with AHA by serving on the Population and Community Health Advisory Committee and also the IFDHE Leadership Council. Thank you so much, Marcos, for being with us today. So let's go ahead and dive into some questions with Marcos. Marcos, let's start by having you tell us a little bit about your roles at CHRISTUS. As I say roles, I know there are numerous roles you play. How have they evolved and possibly changed in recent years?
Sure. Thank you, John, for having me. I'm always very passionate about this topic and love to discuss and talk about it to hopefully move the needle and progress towards achieving health equity. A little bit about my role. Traditionally, CHRISTUS had the diversity and inclusion, the chief diversity officer role has been in function for many, many years. However, in the last 6-7 years, health equity took front center stage, as you can see. Why is that? I think one of the reasons to me is that I see a direct alignment between, there's plenty of studies, right, showing congruency of patient provider in terms of race, ethnicity, and folks being able to build trust quicker and healthcare outcomes related to that and other things. But to be able to connect the diversity of our staff, the diversity of our healthcare providers to the healthcare outcomes that our patients are experiencing, and also understand the public health thing. So it's I see an alignment in terms of D&I as foundational to this work. And then obviously the community health piece, because we want to hear from the public health partners, and they'll tell us this is what's happening in your communities where your hospitals and clinics and other facilities live and care for folks in the community. And those are the folks, what public health agencies are telling us, it's what's coming through our doors. Through the community health needs assessments, as you well know, when you look at the public health data and what we find from our patients, there's a congruency there. There's no surprise. We shouldn't be surprised when we see a CHNA. It's what our public health officials are telling us. It's just that obviously local data ignites in us a fire to really do the work that we need to do to get this going. So that's how, to me, has evolved from that connection of having individuals, because representation matters. If your community is represented within your staff, all the way from executives to the healthcare providers, frontline staff, and everything in between, the issues of your communities are going to bubble up to the surface. That's a need. So that's how I see the connection.
Great. And thank you for pointing that out, because I think in some cases, when you have a chief diversity officer who's also looking at community health and health equity, sometimes those two things trade off against each other and one becomes more dominant than the other.
Mm-hmm.
But to me, it really sounds like you're doing a good job of balancing those roles, because both are very important. You have to have internal inclusion, you have to have a seat at the table, and then the team you create has to be working in the community. So thanks for that.
Yeah, and I would add that why do we exist, right? As healthcare organizations, we're here to provide care. So everything, including D&I functions, have to have an impact on the way we care for people. And minority communities, unfortunately, are overrepresented in vulnerable populations. So there's a direct relationship, no question.
Absolutely. So let's start by looking internally. Share with our audience how CHRISTUS engages with your own team members to increase diversity and inclusion. And are there any programs or efforts you feel have been particularly transformative for your organization, like any aha moments or even a struggle you have overcome to make measurable improvements on the diversity and inclusion front within the organization?
Okay. So we think about this very strategically, because I tell everybody diversity and inclusion and health equity doesn't live in this department. It has to be integrated everywhere. So hopefully at some point my job will be not needed. I don't think it's going to happen anytime soon, but I'm hoping that will be the goal. So what we do is, in terms of strategically aligning it to the rest of the organization, is I look at something called an IIIS model, which is we look at internally, interpersonally, institutional, and then structural. Those are kind of four pillars that I look at this work. The first one internally is, how do we work with our own associates in partnership with our human resources partners, in terms of getting them the knowledge, getting them the information, working on people's hearts is what I call it. The internal is the internal work that we need to do to understand the issues and then, get some passion behind it. Interpersonal is the other piece, which is, okay, now I want to give you some tools for you to be able to cross barriers, to have difficult conversations across lines of differences, to learn about cultural competence and how to relate to the patients that are different than you in all kinds of different demographics and parameters. So that's the interpersonal piece. Institutional is more, what does an organization do? For example, do we have a health equity, diversity and inclusion council, which we do, and it's led by our CEO, which we're very, very grateful for that. The other piece is we have a health equity physicians task force that we want to hear from our docs, primarily doctors that come from historically marginalized communities, hear what's happening in the field with their patients and around things like celebrations, because those things are important. They're very D&I focused, but they're very important in terms of ensuring that there's an education happening on a regular basis. Diversity and inclusion leadership awards. Those are institutional things that communicate loud and clear that this is an important strategy for us to succeed. So that's the institutional piece. And then under institutional also, we have a strategic map called Connect 2025, in which the organization have about 12 to 14 goals for the whole system. From quality to finance to mission to culture to patient experience, quality care, et cetera. So we do have a health equity goal in that strategic map. And we also have a diversity and inclusion goal And we also have a community benefit goal. So out of those 12 to 14 strategic focus areas that we have for the system, 3 of them belong to this area, which I'm super proud of, because that, again, is a way to integrate this function into the day-to-day operations. So that's the institution. And then systemic is, how do we deal with our communities? What are our communities saying about us? How well do we have a listening ear? Do we have, like, we have a learning collaborative with 60 different nonprofits that we meet every quarter. We hear from them, they hear from us. And it's a great opportunity for us to stay in touch. But that's the what I call the systemic piece. I'm sorry. So it's internal, interpersonal, institutional, and then systemic. And systemic is how well our hospitals function, which within the community, which is the system.
Well, that's great, because I really like the fact that as a system, you have incorporated DEI and health equity into expected performance measures for team members and for leaders. Because I think that says a lot about an organization when they make it a priority, particularly when they tie it to performance evaluations and or outcome measures for leaders. That's really great. So now I want to turn and look externally, because we all know that health systems and hospitals can't do all of this, can't do everything to address health equity. We have to have numerous external partners. The patients and communities we serve and that your hospitals serve. Can you share with us your approach to meeting the specific unmet needs of those communities, and how you're removing barriers to care and improving access to equitable health care, and how partnerships play into that?
You know, what's really interesting, you know about the new CMS and Joint Commission requirements around social determinants and D&I, which has even pushed this work even forward even more. So what I see is the community health needs assessment. Obviously, we have all these focus groups, and we talk to all the stakeholders in the community. We hear that, plus the data from our public health agencies are telling us, plus our internal data. All that comes together into an assessment. So we're able to have. We also have what's called the CHRISTUS Impact Fund, which is whatever we decide as a system is really critical for us as a result of the community health needs assessment. In this case for us, this 3 calendar years, it's going to be heart disease and food insecurity. We try to say, okay, that doesn't mean we're not going to, be concerned about other things, but those are the main 2 that we're going to focus on. And we're able to then, through the Community Impact Fund, help assist some of our community nonprofits to help us with that. Whether it's, okay, let's focus those resources, those monies, to giving grants to food banks, to giving grants to organizations that are helping us advance heart disease and other things. So that's kind of a way for us to hold hands, if you will, and come together and be a partner. We're not leading anything. We're just being a partner in a round table. And that to me is important. I mentioned a little bit about the Learning Collaborative, and that has been, again, super successful in us being able to hear, because that's one of the things that I think health systems in general have been criticized for, is that have we listened to folks? And I think this provides that venue for us to really do that. So that's been very important. But I tell you, even with the CMS requirements, we were able to talk to our quality and patient safety partners and said, guys, heart disease and food insecurity is what we want to focus on according to our CHNA. Let's just continue that even through this requirement, and we're going in that direction. So it's very exciting to me to see the community voice impacting what we do in the hospital, and then everybody getting in line, aligning, if you will, not getting in line, but aligning, getting in line too, I guess.
Yes, everyone's sharing their responsibility, that's for sure.
Yeah.
So, I oftentimes get asked, and I'm sure you have too, about the ROI question when it comes to investing in health equity and community health. So I'm going to turn that question on you today. How have you successfully made the business case for this work to ensure that it remains woven into the fabric and strategic mission of your organization?
I think it's we are set up a little bit different, John. I report through mission integration. So the ROI it's already been in terms of creating culture of who we are as an organization. It's been there. So I don't have to really, in terms of creating a pro forma, a whole business plan and ROI on this. I have done that before. But obviously, and I can tell you the typical answer would be cultural competence, impact healthcare outcomes, decrease healthcare costs when you have a diverse leadership and board, that the organization normally performs better financially. We all have seen those. But I think the bigger question to me is, I have a feeling you were going to ask that, but I said, let me turn that around a little bit for us as healthcare leaders to think, if there's real healthcare quality without equity. I think that's what we as leaders need to be asking ourselves, and I think that kind of help answer a little bit. When we think about our values as organizations, I think for us at CHRISTUS, one of them that to me is very clear is dignity. So how do we preserve the dignity of every human being that comes through our doors? And I think that does indeed an ROI. It's very clear. Now, I will tell you that doesn't mean I don't measure outcomes. We do. We had an equity of care program in which we followed our Medicaid uninsured patients from historically marginalized communities. We look at their data in terms of hospital utilization and hypertension. And by creating a navigation program for these patients, the length of stay went down, the 30-day readmission rates went down, hospital visits went down. So yes, there's an ROI there. And I think that's very clear. But we try to approach this work as this is who we are as an institution. Obviously, it needs to make financial sense. And I'm a huge advocate of, could somebody talk to CMS and hurry up and get the community health workers interventions reimbursed, please?
Yeah.
Just directly, because there's nothing else to prove here. It's so clear that it has such a great impact on patient care.
Oh,
so that's what I would answer, John.
No, you're absolutely right. The community health worker element within all of this work is critical.
Yeah.
Because the more boots on the ground we have in the community to work with communities on improving health, the better off we all are.
Yeah.
As we know, the reality is that not every hospital or health system has been as successful or is as far along when it comes to hardwiring health equity into their day-to-day work. I know this could be a conversation in itself, but what suggestions do you have for other organizations, any must-dos as it relates to improving diversity and inclusion within their organization?
Yeah, I think I would say a few things. Number one, I think it has to be hardwired into the mission and into the strategic map of the organization. You gotta have health equity goals and D&I goals and community benefit goals in there. I think that communicates volumes to everyone across the organization. So incorporated into the scorecard. The other piece that to me is really important is, while I don't report directly to the CEO, I do meet with him on a quarterly basis to give him updates as to how we're progressing in the health equity piece and in the D&I piece as well, and community benefits. So either having the person or the department either reporting directly or somehow having a connection on a regular basis is important, as you know. So that to me is a huge recommendation. Have a health equity diversity and inclusion council that has executive representation and folks that can make decisions in it. I think historically in the past, I remember myself having diversity councils that were representative of the staff and that's great. But if you don't have decision makers at the table, it frustrates that group. And that's in my old experience, even before being here. So having a heady council that is a good mix of executive sponsorship and other folks as members is to me really important. And I cannot reiterate enough the connection to the CEO. That's really key.
That's great. No, that's good. A little follow-up to that I'd like to ask is, I personally believe that understanding the social determinants of health that are impacting the communities we serve is really imperative for us to develop our action plans around health equity. You know, what are those health social determinants that are impacting health negatively in the community? What is your elevator speech, or what would you share with the people tuning in to this discussion about the need to really focus on social determinants?
To me, if we want to have the best healthcare outcomes for all communities, we have to. I mean, we have to go upstream. I think the social determinants, such as, you know, lack of access to care or housing or food insecurity or others, if they're not taken care of, once we care for patients in a great way, right? But we have no control over what happens once they leave. If we don't have an influence and include that discharge after they leave the hospital into the care continuum, they're going to continue to come back. And that cycle is going to be very hard to break. So to me, talking about ROI, talking about wanting to provide excellent quality care, wanting not to frustrate your healthcare providers, care for those things, because they're the ones that are going to keep patients healthy outside of the hospital, and performance as an institution will go high. So to me, absolutely, there's a direct relationship, and we have to take care of that. And excellent care and quality care doesn't exist without that equitable piece. Just add it to the care continuum. Think like there's no division there. It's part of what we do.
No, great. Thank you for that. And that's a great way to wrap up our time together. Marcos, I want to thank you again for joining me today. Your insights and expertise are valued. AHA's Community Health Improvement Network and IFDHE are hosting the Accelerating Health Equity Conference next month, May 16th through 18th in Minneapolis, where you can learn from experts in the field and dive much deeper on these topics that we have scratched the surface of today. To register or learn more, you can visit www.equityconference.aha.org. Thank you for joining us today, and I hope you'll be back for next month's Leadership Dialogue. Thank you.